Hello everyone. Today we are going to talk about acute phase reactants, which of course include C-reactive protein and also indirect measure of acute phase reactants, that is ESR. And every doctor must be master in interpretation of C-reactive protein and interpretation of ESR. Now, these two are actually acute phase reactants, right? C-reactive protein is one of the acute phase reactant, and ESR depends on fibrinogen mainly, but many other acute phase reactants. But before we go into detail of C-reactive protein and ESR, let us first make the concept that what are acute phase reactants, right? Actually, acute phase reactants are a group of proteins, present in plasma, which significantly increase or decrease in their concentration whenever there is damage to our body. Whenever there is damage to our body, inflammation is to our body, or infection is there, right? Whenever there is damage to our body, some plasma proteins levels significantly change, right? What I mean by significantly change, significant mean that these proteins from their baseline increase in their concentration at least 25% or decrease in their concentration at least 25%, right? That whenever there is damage to our tissue, whenever there is inflammation, whenever there is infection, whenever there is surgery, trauma, ischemia, or autoimmune damage, allergic reactions, neoplasia, even metabolic stresses, right? Like central obesity or psychological stresses or environmental and chemical stresses like air pollution, radiation, heavy metal, pesticides, smoking, alcohol, all these things which damage our body, inflammations and infections, trauma, everything, whatever damages our body significantly, our innate immune cells are activated. Our innate immune cells like neutrophils, macrophages, monocytes. Of course, monocytes are circulating cells, and when they go into tissue and they become active, then they extravasate and go into tissue from circulation, we call them macrophages. So whenever there is damage in the body, whenever our tissues are damaged, innate immune cells are activated, right? We will discuss later how they are activated, but they are activated. Which cells are activated? Neutrophils, monocyte macrophage system, dendritic cells, even mast cells, adipocytes, especially in central obesity, and then there are epithelial cells, there are natural killer cells, there are fibroblasts, there are endothelial cells. But I don't want you to remember all of them. Just remember 3 or 4 most important cells, which you should not forget. Whenever tissue is damaged, dendritic cells are activated, neutrophils are activated, macrophages are activated, right? And natural killer cells are activated. This is the minimum you should remember. When these cells are activated, when these cells have sensors, they sense the danger, they sense the pathogens, they sense there is ischemia or there's tissue damage or there is any type of stress. We will talk about these sensors also later. When these cells sense the stress, they are activated and they start releasing pro-inflammatory cytokines. Remember, there are some cytokines which are pro-inflammatory and there are other cytokines which are anti-inflammatory, and balance of these two types of cytokines help us to regulate inflammation, right? But these pro-inflammatory cytokines specially include interleukin 1, interleukin 6, and tumor necrotic factor. There are other also, but at least these are the three you should know when we talk about acute phase reactant. That injury in the body, activation of the innate cells like macrophage, neutrophil, and natural killer cells, dendritic cells, production of pro-inflammatory cytokines like interleukin 1, interleukin 6, tumor necrotic factor. And if you cannot remember all these three, at least remember one most important cytokine, which is interleukin 6 as far as acute phase reactants are concerned. Now what happened? Let's suppose there is inflammation or injury to my arm. Many dendritic cells, macrophages, neutrophils, natural killer cells activated as a part of the innate immunity as first line of defense, right? And they release pro-inflammatory cytokines in blood, interleukin 1, interleukin 6, interleukin, and tumor necrotic factor alpha. Through the circulation, right, these cytokines will reach many tissue. But right now I will focus only on your beautiful liver, that these cytokines will reach your liver, and number one, they will directly act on the hepatocytes. Number two, they will act on the Kupffer cells in the liver and force the Kupffer cells to produce more tumor necrotic factor interleukin 1 and interleukin 6. So what is happening? That from the arm which is injured, right, we are receiving interleukin 1, interleukin 6, and tumor necrotic factor via the blood to the liver. Number two, these cytokines directly act on the hepatocytes, and they also act on Kupffer cells, right? They also act on the Kupffer cells, and Kupffer cell also start producing interleukin 1, interleukin 6, and tumor necrotic factors. Now these all pro-inflammatory cytokines which are coming from circulation and also produced by the Kupffer cells, when they stimulate the hepatocytes, you know, hepatocytes are one of the very important cells which produce different plasma proteins. When these pro-inflammatory cytokines act on the hepatocytes, hepatocyte start producing some proteins in plasma in increased concentration, and start reducing the production of some of the plasma proteins, right? For example, when these inflammatory cytokines act on the hepatocyte increase the production of C-reactive protein, ferritin, ceruloplasmin, fibrinogen, serum amyloid associated protein, and many other. We'll talk later. So one group of proteins are produced more than normal and released in blood from hepatocytes, and there is another group of proteins, their production is reduced and they are being released in blood in reduced amount. So what will happen? The first group of proteins concentration in the blood will go up, and second group of proteins in the plasma will go down, right? Now this first group of proteins, right, which are going up, we call them positive acute phase reactants. We call them positive acute phase reactants, right? And those proteins where level in the blood goes down, they are called negative acute phase proteins. Acute phase proteins, right? Now, let me redefine the things. Now, what are acute phase reactants? Acute phase reactants, more appropriately called acute phase proteins, are those proteins present in plasma which increase or decrease at least 25% of their concentration whenever in the body there is injury, inflammation, infection, or any kind of stress, right? And those those acute phase proteins or those acute phase reactants which increase in concentration, we call them positive acute phase reactants. And those which decrease in concentration in plasma, we call them negative acute phase reactants. We call them negative acute phase reactants, right? Now, we are clear about three things. What are acute phase reactants? Mostly they are proteins. So we can call them acute phase proteins. From where they are produced? They are produced by the hepatocytes liver. How they are produced? First, injury in the cell, injury to our tissue or stress to our tissue, right? Leading to activation of innate cells, producing pro-inflammatory cytokines, acting on the liver and changing the production of certain plasma proteins. Plasma proteins going up, positive acute phase proteins or acute phase reactants, plasma proteins levels going down, negative acute phase proteins or acute phase reactants. Even though most of the doctors, they talk about, when they talk about acute phase proteins, they only remember, they don't remember, then there are some other molecules which also change in the blood, right? And most of the time, we doctors discuss about the acute phase reactants. When we talk about acute phase reactants, most of the time, good doctors talk about acute phase proteins. But you know, there are always some very good doctors, right? Very good doctor know that not only there are acute phase proteins, there are some other molecules in the blood. Yes, there are some other molecule other than the proteins present in the blood which show acute phase behavior. These molecules which I'm going to discuss, they are also considered acute phase reactants, but they are not acute phase proteins. Let me repeat it. It means acute phase reactants are mostly acute phase proteins or protein in nature, but there are some other molecules also which I'm going to talk. They also show acute phase behavior. What I mean by acute phase behavior? I mean that there are some other molecules other than the plasma, certain plasma proteins, there are other molecules which increase or decrease in concentration whenever our tissue is significantly damaged, right? Right. So what are those molecules? They are, that is iron. Iron level goes down in the blood in acute phase as acute phase reactant. Then zinc level also goes down. ZINC, zinc level also goes down. And then, of course, you should not forget copper. Copper level goes up in the plasma. What does it mean? It means that iron and zinc are negative acute phase, they are behaving as negative acute phase reactants. and copper is behaving as positive acute phase reactant. And I will not go into detail, but certain vitamins levels also fluctuate. Most of these fluctuations in plasma or serum vitamin level is due to actually changes in vitamin binding proteins, right? We will not go into detail, right? So up to now, what did we learn? Number one, what are acute phase proteins, right? Acute phase proteins or acute phase reactants are those proteins which are present in the blood and on any type of injury, trauma, injury, infection, any stress, any type. It may be infection, inflammation, or surgery, trauma, ischemia like myocardial infarction, autoimmune diseases, allergic reactions, even in neoplasia, they also damage our tissues. Extreme exercise, that also damages our cells, muscles, and produce and there are changes in acute phase reactant. Metabolic stresses, right? Metabolic stresses like central obesity, right? Or uh, insulin resistance, right? That also changes acute phase reactants. Then prolonged psychological stresses, they also change acute phase reactant. Action is through the limbic system, hypothalamus, and then producing neuroendocrine changes, which eventually translate into changes in acute phase reactant. And now we believe with the latest research, even environmental and chemical stressors like severe air pollution, radiation, heavy metals, pesticides, smoking, alcohol, they increase the level of acute phase reactants in our blood. Remember, these acute phase, of course, I should not say they increase the level of acute phase reactant. So please correct it. We should say they change the level of acute phase reactant because some of them are positively increased and others are negatively decreased, right? And what else we learned? That those acute phase reactants which go up are positive acute phase reactants, which go down are negative acute phase reactants, right? The detail of acute phase reactants I will discuss in next lecture, right? There is a lot of important information we have to discuss in detail: C-reactive protein, ESR, and many other. But right now, I will just name the acute phase reactants. First, I will name the positive acute phase reactants, and then I will name the negative acute phase reactants, right? Let's start with the positive acute phase reactants. Remember, I'm not going into detail. For example, C-reactive protein, which is positive acute phase reactant, I will just say a few words about it. But later on, there will be a full lecture of 2 hours lecture of basics and clinical implications of C-reactive protein. But right now, I'm just briefly mentioning positive acute phase reactants. These are the important one. I'm not going to talk all of them. I will just tell you the important one. First of all, C-reactive protein. Of course, it is produced by the liver. C-reactive protein act as an opsonin. What is the importance of it? Why liver produces this protein? There's a purpose, because when there is damage going on and pro-inflammatory cytokines are released by the innate cells and hepatocytes are increasing some proteins and decreasing other protein, there is a purpose in it. Those proteins where concentration is increased, right, and those which are decreasing their concentration, both of them in one way or another way help our body to fight with the trauma or infection or the stress and help our body to repair, right? Let's start one by one. First of all, positive acute phase reactant, but very briefly. right? One by one, I will mention. First of all, if you want to remember only one positive acute phase reactant, please never ever forget C reactive protein, right? Now, what C reactive protein is doing? It must be doing some benefit in such stressful situation. Actually, C reactive protein act as opsonin. C reactive protein binds with certain molecules on bacteria and also binds with certain molecules on our injured tissues. Number one. Now, what are those molecules? Those molecules are phosphocholine. Actually, bacterial cell membranes and even human cell membrane, within that membrane, they have a hidden molecule within their plasma membrane or cell membrane. The hidden molecule is phosphocholine. When bacteria are damaged or when our cells are damaged, phosphocholine is exposed exteriorly. When phosphocholine is exposed, what will happen? C-reactive protein will bind there. Now you imagine many bacteria, their membranes are having C-reactive protein sticking there, and our damaged cells exposing phosphocholine, they are also having C-reactive protein sticking to them, but our healthy cells are not binding C-reactive protein, because in healthy cells, C-reactive protein is, phosphocholine is hidden within the membrane. They are not exposed on the surface. Now, when C-reactive protein stick to the pathogens and to our damaged cell, they act as a red flag. Number one, they act as opsonin. How they act as opsonin? Actually, C-reactive protein receptors are present on neutrophils and macrophages. So neutrophils and macrophages can bind with C-reactive protein, and now look, C-reactive protein on one side is binding with our injured cells or pathogen, and other side it is binding with the receptor on macrophage or neutrophil. So actually C-reactive protein on injured cell or pathogen is binding on the exposed phosphocholine and binding on other side with neutrophil and macrophages and activating the phagocytic process. And when bacteria or injured cells are sticking with the macrophages or neutrophil via the C-reactive protein, then bacteria or injured cell cannot escape neutrophils or macrophages. Now neutrophils or macrophages will very easily phagocytose them. Such molecules are called opsonins. So C-reactive protein is opsonin. Okay, let me define what is opsonin. Opsonin is any molecule which can bind with any particulate matter in our body. This particulate matter may be some bacteria or maybe some our damaged cell or whatever. What are opsonins? Opsonins are the molecule which can bind with particulate matter in our body and facilitate the phagocytosis by the neutrophils and macrophages. Right? So what is opsonization? Opsonization is the process in which a molecule, opsonin, is bind on one side to the pathogen or injured cell, on other side bind to a phagocytic cell and facilitate or accelerates the phagocytic process. This is very important because when there is injury, our cells, injured cells, should be removed rapidly. You know why? Because if they stay in our body for a very long time, there is an increased risk of production of autoimmunity, right? So C-reactive protein not only help us, increased level of C-reactive protein not only help us to remove the pathogens, but also help us to clear our injured cells or apoptotic cells, right? One more function of C-reactive protein. C-reactive protein can activate, once it binds on the pathogen or injured cell, it can activate classical complement pathway, which is activated by C1q. This is one function of the C-reactive protein. Was it was a directly opsonin and facilitating the phagocytosis. Second function is that C-reactive protein can basically, once it bind with its target, like pathogen or injured cell, then it can activate the classical pathway of what? Complement system. And that complement system, when it is activated, it can produce activated fragments. A special mention should be C3b, which also act as opsonin, C5, C5a and C3a, which act as chemotactic agent for phagocytic cells, neutrophils, macrophages, and it can also produce special terminal complex, terminal part of complement factors, which eventually make punch holes in the membranes of bacteria or injured cell and help them to eliminate, right? We call them membrane attack complexes from complement system. So here what I wanted to tell you that C-reactive protein is very important to increase in the blood so that it can help us to fight infections and injured tissue. But remember one thing, when we measure C-reactive protein level in the blood, it is a non-specific marker of inflammation. It only tells inflammation is going on, but only C-reactive protein does not tell us what kind of inflammation is going on, what is the underlying cause of inflammation. We have to interpret other clinical and laboratory data to make a final diagnosis. C-reactive protein only tells that inflammation is going on. A beautiful thing about C-reactive protein is it has a short half-life and it is very rapidly produced. It means when inflammation starts, if inflammation is going up very rapidly, its production goes up. And when inflammation is going down, its production goes down, and whatever is previously produced rapidly disintegrate due to its short half-life. What does it mean? It has a clinical significance. We can say C-reactive proteins, reactive proteins levels in the blood actually follow the fluctuations of inflammatory process very accurately. If inflammation is going up, C-reactive protein levels in the blood will be rapidly increasing, sometimes 1000 times more than normal. And if inflammation is going down, C-reactive protein levels will rapidly go down. That is why C-reactive protein can also be used to monitor therapy, treatment. For example, if someone has heavy inflammation and you are giving certain anti-inflammatory drugs and you want to see that disease is responding or not, one way is to do C-reactive protein very frequently, sometimes daily, to see that how the inflammatory process is responding to your therapeutic intervention, right? Yes. Then we will go to another thing, another positive acute phase reactant. Acute phase reactant. That is Fibrinogen. Now, Fibrinogen is a large molecular weight protein. It's one of the coagulation factor. During acute inflammation or even chronic inflammation, liver produces more fibrinogen. So fibrinogen levels in the blood increase, right? And when fibrinogen levels in the blood increase, of course, then it is positive acute phase reactant. Advantage is that whenever there is injury going on, if there's more fibrinogen, more easily process of coagulation can occur, right? And not only injured point in cardiovascular system can be plugged, but fibrinogen can also help endothelial cells to repair themselves. The most important thing at this level, I want to mention that raised level of fibrinogen is one of the major determinant of ESR. ESR, erythrocyte sedimentation rate, a commonly done lab test, mainly depend on serum or plasma fibrinogen level, 70 to 80%. There are many other factors also which influence the ESR. Those factors we will study in a separate lecture, the lecture which will come with the heading of ESR. But here I just want to tell you, fibrinogen is an positive acute phase reactant, which is 70 to 80% contributing to the erythrocyte sedimentation rate, along with some other acute phase reactants, or it includes gender and age, and also ESR is dependent on morphology of the red blood cells. Or many other proteins. I will not go into detail now. For now, it is enough to know that fibrinogen is the major determinant of ESR. Here I want to tell you something very important. Fibrinogen levels as acute phase reactant, as a reaction to the tissue damage, infection or stress, fibrinogen levels gradually increase in the blood, and fibrinogen has relatively long half-life. So when inflammation subsides, then fibrinogen level gradually decrease in the blood. It means that if we are having an inflammatory process going on which is fluctuating, then C-reactive protein more faithfully follows the fluctuating pattern of inflammation. But if inflammation is going up in our body, ESR will show delayed elevation. And if inflammatory process is going down, then ESR will reduce with a significant delay. That is why, because C-reactive protein levels rapidly go up and rapidly go down with inflammatory situation, right? That is why C-reactive proteins can be checked in blood in severe cases of inflammation every day. But these tests can be repeated to evaluate the inflammatory state of the patient every day. But ESR is usually requested weekly. If there is a chronic inflammatory condition, in that case, if we have to do ESR repeatedly to look for the patient inflammatory conditions behavior, we don't do it daily. We do it weekly. This is one thing. Secondly, I want to tell one thing. When we say, listen with your both ears, it is a very important thing. Even though these proteins which fluctuate in the blood significantly on inflammation or infection or stress, we call them acute phase reactants. But this is a misnomer, because these proteins not only increase or decrease during acute inflammation, but their level also increase or decrease depending on it is positive APR or negative acute phase reactant. even in chronic diseases, right? So what we can say that acute phase reactants, even though their name is acute phase reactants, but actually not only they change their concentration in plasma significantly, not only in acute inflammatory states, but also in chronic inflammatory state. So we had few words about C-reactive protein, and then we had about fibrinogen, right? Now we come to some other acute phase reactants, which are positive acute phase reactant. Before I go for that, I want to tell you one thing. You know, many of the pathogens or bacteria, they require iron. They require iron for their metabolism, their proliferation, and their pathogenicity. So, our body changes certain proteins in such a way, our body changes certain plasma proteins levels in such a way that iron is not easily available for pathogens. It's worth repeating that when there is infection, many bacteria, they need iron for their metabolism. And we have iron in our body. We don't want bacteria to use that iron. So what we do, our liver, under the influence of pro-inflammatory cytokines, especially under the influence of interleukin 6, our liver changes plasma proteins in such a way, some of the plasma proteins in such a way, some of the plasma proteins are increased, others are decreased in such a way that availability of iron for the pathogens become less. Let's look for those proteins. First of all, I will tell you about haptoglobin. I will tell you about haptoglobin. Now, haptoglobin is normally a plasma protein produced by the liver. The normal function of the haptoglobin is that whenever there is hemolysis intravascularly, what I mean by intravascular hemolysis, I mean by that circulating red blood cells break down and release free hemoglobin in circulation. For example, it can happen in malaria, in transfusion reactions, in some autoimmune hemolytic anemias, right? So when there is intravascular hemolysis, red blood cells break down within the circulatory system. They release the hemoglobin free into circulation. Remember, this free hemoglobin is a toxin. As far as hemoglobin is within the RBC, it is very good. We love hemoglobin. It carries oxygen for us, right? But if hemoglobin is not packed in the red blood cell membrane and hemoglobin become free into blood, it become a very, very toxic molecule. You know why? Because hemoglobin is a tetrameric molecule. It breaks down into dimers. One tetramer divided into two dimers, and these dimeric hemoglobin filter through the glomerular basement membrane. And from there it comes to proximal convoluted tubule. And unfortunately, our proximal convoluted tubular cells love to eat the hemoglobin. And when they take up the hemoglobin in the nephron cells and proximal convoluted tubular cells, globin component is catabolized into amino acid. Iron is extracted out of the heme component, and this iron is in ferrous form, and it produces free radicals and damages proximal convoluted tubular cells. What does it mean? It means whenever hemoglobin molecules are out of red blood cell membranes, they can filter into glomeruli. Their dimers can be taken up by proximal convoluted tubular cells, and there this hemoglobin molecule, when it is catabolized, free iron which is released, it is highly toxic to the proximal convoluted tubular cells, and it may lead to acute tubular necrosis. Patient will develop hemoglobinuria and even oliguria, even anuria, and this patient may go into renal failure. So nature has been very kind to us. Liver produces a protein haptoglobin. As soon as red blood cell breakdown in circulation, free hemoglobin is available, haptoglobin will stick with that hemoglobin. And now hemoglobin is not free, it is binding with haptoglobin. When hemoglobin binds with haptoglobin, right, now it cannot be filtered into glomeruli. This complex hemoglobin haptoglobin complex is large enough not to be filtered in proximal convoluted tubular cell. Filtered in glomeruli. So what happens? They remain in circulation, and haptoglobin receptors are present on macrophages and Kupffer cells. And what happens? Macrophages and Kupffer cell phagocytose hemoglobin haptoglobin complex. Now hemoglobin is transferred to the macrophages. Within the macrophages, hemoglobin is broken down into globin component and heme component, and from the heme component, macrophage extract the iron. But iron does not damage macrophages. You know why? Because macrophages have one more protein, ferritin. They bind the iron with ferritin and store the iron safely, so that it can be used later on, maybe for again erythropoiesis. You are understanding? Now what happened? After you have understood this basic concept, now you understand one thing. Whenever there is damage in our body, there are chances capillaries are damaged. There are chances there can be some hemoglobinemia, free hemoglobin in the blood. You know, those innate cells, you remember? Macrophages, dendritic cells, neutrophils, natural killer cells, which produced pro-inflammatory cytokines like interleukin 1, interleukin 6, tumor necrotic factors. These pro-inflammatory cells, when they acted upon hepatocyte, they increase the production of haptoglobin. Whenever there is injury in the body, haptoglobin level also in the blood increase. What this haptoglobin is going to do? It is going to bind with any free hemoglobin if it is there, and immediately that complex will be taken up by macrophages, and that iron which will come out of the hemoglobin will be stored in macrophages as a component of ferritin, and this iron will not be available to the pathogens. And this iron will not be available to pathogens. Then another thing, not only liver increases production of haptoglobin to catch the hemoglobin and preserve its iron, liver also produces another very important protein. This is called ferritin. Plasma ferritin levels also goes up. It means ferritin is also acute phase reactants, right? And what ferritin is doing, wherever free iron is there, ferritin will bind and store this iron in macrophages, right, in Kupffer cells and other cells, so that this iron is again not available for pathogens. So we don't want bacteria or pathogens to get iron from our body and damage us by increasing their own metabolism. So our biological system is clever enough to store or sequester our iron in such a way that it is made unavailable to the pathogens. One thing I told you, produce more haptoglobin. Second thing I told you, produce more ferritin. Right? Both conditions reduce the availability of iron for the pathogens. Now come the third thing. First basic, then I will tell you the molecule. The basic is from where the iron comes to the blood. There are two sources. Number one, dietary iron. Dietary iron is absorbed by the mucosal cells in duodenum, right? And stored iron, which is present in the macrophages, in the liver, spleen, and bone marrow, stored iron can be released from macrophages. So our blood can get iron either from GIT, that is new dietary iron, or it can get iron from the stores. But there is one thing. Mucosal cells in the duodenum, when they absorb iron through special mechanisms from their apical surface, right? Once iron is in the cytoplasm of mucosal cells of duodenum, this iron, intracellular iron, needs to be released to the circulatory system. For this purpose, there is a small door, we call it iron door, which is taking iron from mucosal cells of duodenum to the circulatory system, to the interstitial fluid and circulatory system. That special molecule which makes the transfer of iron from mucosal cells to the blood, a little door for iron, that is called ferroportin. Ferro, F-E-R-R-O, ferro, P-O-R-T-I-N, ferroportin. So in the duodenum, in the mucosal cell, on their basolateral membrane, what is there? Ferroportins, which transfer the iron from the mucosal cells of the GIT to the blood. Number two, when we want to utilize stored iron, the stored iron which is present in macrophages of liver, spleen, and bone marrow, when we want to release iron from there for erythropoiesis, right? There are also iron doors through which iron can escape from macrophages to circulation, right? Those doors are also actually ferroportin. Those are also ferroportin. Now you imagine if, now look, we don't want iron in blood. We don't want pathogens to take iron. So one more strategy is there that destroy the ferroportins. If we destroy the ferroportins molecule present on basolateral membrane of mucosal cells, we cannot absorb dietary iron. And if we destroy or digest or disintegrate ferroportins of macrophages, we cannot release the stored iron, right? You know, there is a protein which destroys ferroportins. The name of that protein is hepcidin. H-A-P, hepcidin. H-A-P-C-I-D-I-N. Hepcidin. Now what happens? During inflammatory states, liver produces a lot of hepcidin. So hepcidin is a positive acute phase reactant. What hepcidin is doing? Yes, hepcidin is destroying the ferroportin on gastrointestinal system, duodenal mucosal cells, basolateral side, and hepcidin is destroying ferroportins on macrophages. So we cannot get the new iron, we cannot mobilize the stored iron levels in the blood go down, and that will result in poor iron, less iron for pathogens. But remember, in chronic inflammatory conditions, that for a very long time, if ferroportins are destroyed by hepcidin, this is for a very long time, like in patient with rheumatoid arthritis or patient with tuberculosis. In chronic condition, hepcidin circulating levels are high as acute phase reactants. You know what happened? That iron is available in our stores as ferritin, but we cannot mobilize the iron and cannot utilize the iron for erythropoiesis. And patient has anemia of chronic disease. Anemia of chronic disease. Anemia of chronic disease is the anemia which occurs in chronic disease, has multiple causes, but one of the important causes due to chronic disease and chronic inflammation, high levels of hepcidin don't allow the new iron to be absorbed, don't allow the sequestered iron or stored iron to be mobilized, and ferritin levels in the body are high. Ferritin levels are high, but free iron is less. This is very important to understand. If there is iron deficiency anemia, then iron is low in the blood, ferritin is also low in the blood. But in anemia of chronic disease, ferritin levels are high, but iron levels in the blood are low. So now we have seen three molecules which are acting as positive acute phase reactant, and they are trying to make the iron less available to pathogens. What are these positive acute phase reactant? Number one was haptoglobin, which bind with hemoglobin and transfer the hemoglobin safely to the macrophages, and iron is released in the macrophages, and there it binds with apoferritin and convert into ferritin. And second was hepcidin, which has destroyed the ferroportins on mucosal cells. New iron is not absorbed, and also ferroportin destroyed on the macrophages, and stored iron cannot be released efficiently. And third molecule I should mention, I have mentioned haptoglobin, I have mentioned ferritin levels are also increased, and I have mentioned hepcidin. Up to now I have mentioned three what? Positive acute phase reactant, which are actually reducing availability of iron. That is ferritin, which binds and sequesters more iron, haptoglobin, which transfer the hemoglobin to the macrophages, and there iron is bound with apoferritin, converted into ferritin, and then hepcidin, which is also not allowing the absorption of new iron and not allowing to mobilization of stored iron. These three proteins, ferritin, haptoglobin, and hepcidin, all three go up in the blood. But there is one protein related with iron which goes down in blood. That protein is transferrin. Now, while in inflammatory conditions, in acute and chronic, ferritin levels, haptoglobin level, or hepcidin levels are going up, but plasma transferrin levels go down. And it is also good for us, not for bacteria. You know why? Liver is producing transferrin less because function of the transferrin is to transfer the iron in blood. For example, if iron from absorbed from the GIT will be transferred on the taxi of transferrin. Transferrin is taxi for iron in the blood. If we need stored iron to be released, when iron is released from macrophages from ferritin, it immediately binds with transferrin taxi because free iron is toxic. So in the blood, transferrin is the protein which transfer the iron eventually to the erythropoiesis, and if pathogens available, it can transfer the iron to pathogens also. So our liver is very clever. It reduces the production of transferrin. So ability of the blood to transfer the iron here and there is reduced so that we deprive the pathogens wherever they are in the body of the iron. So now you should remember in acute phase reactant, there are 4 proteins which are managing the iron in such a way that iron should not be available to the bacteria or pathogens. 3 are positive APRs, that is haptoglobin, ferritin and hepcidin. 1 is negative APR, which is transferrin, right?